A patient suddenly develops facial drooping. They can't smile properly on one side. One corner of the mouth hangs lower than the other. The emergency department immediately thinks stroke. But before ordering scans, there's one simple thing you should look at. Ask the patient to wrinkle their forehead. That single finding can often tell you whether the problem is in the brain itself or in the facial nerve. This is Bell's palsy versus stroke explained. Let's start with stroke. A stroke-causing facial weakness is usually an upper motor neuron lesion affecting the motor cortex or corticobulbar tract before the facial nerve exits the brainstem. Imagine a stroke affecting the left motor cortex. The right lower face loses its only cortical input and becomes weak. However, the right forehead still receives signals from the healthy right hemisphere. As a result, the patient can still wrinkle their forehead and raise their eyebrows. This is called forehead sparing. It's the hallmark of an upper motor neuron facial weakness. Now compare that to Bell's palsy. Bell's palsy is a lower motor neuron lesion of the facial nerve itself, usually caused by inflammation and swelling of cranial nerve 7, often associated with reactivation of herpes simplex virus. Because the lesion occurs after the nerve has left the brainstem, all fibers within that nerve are affected. The forehead fibers, the eye closure fibers, the cheek muscles, the mouth muscles, everything. As a result, the entire half of the face becomes weak. The patient cannot wrinkle the forehead, cannot raise the eyebrow, cannot fully close the eye, and cannot smile normally on the affected side. This is complete ipsilateral facial paralysis. Now let's compare the clinical features. In Bell's palsy, the entire side of the face is involved, forehead movement is lost, eye closure is impaired. Patients may complain of altered taste sensation on the anterior two-thirds of the tongue. Some develop hyperacusis, where ordinary sounds seem unusually loud due to involvement of the stapedius muscle. Mild pain around the ear may occur before the weakness develops. Importantly, Bell's palsy does not cause arm weakness, leg weakness, aphasia, or visual deficits. Stroke is different. Facial weakness is often accompanied by other neurological deficits. Patients may have arm weakness, leg weakness, speech difficulty, visual disturbances, or gait abnormalities. And most importantly, the forehead is usually spared. Diagnosis of Bell's palsy is largely clinical after excluding stroke and other serious causes of facial paralysis. Treatment involves corticosteroids started within 72 hours, along with eye protection to prevent corneal injury from incomplete eyelid closure. Stroke, on the other hand, is a medical emergency requiring urgent neuroimaging and rapid treatment to restore cerebral blood flow when appropriate. The key takeaway is simple. Bell's palsy is a lower motor neuron lesion causing weakness of the entire side of the face, including the forehead. Stroke is usually an upper motor neuron lesion causing weakness of the lower face while sparing the forehead. Remember this one rule. If the forehead moves, think brain. If the forehead doesn't move, think facial nerve. Master that concept, and you'll answer most Bell's palsy versus stroke questions in seconds. This is the Why Medic. Subscribe for more high-yield topics.